Good afternoon. Myself, Dr. Jitendra Khandelwal, Associate Professor, Department of General Surgery. I'm going to take your class on general surgery. This is my first class for your batch. Today we will discuss relatively less common topic, but it's very important in our body: omentum, mesentery, mesenteric cyst, and retroperitoneal spaces, and the common entities involving these structures. First of all, I would like to go for omentum. As we all know, I think so, you should also know what is commonly called for omentum in our body. What we say, policeman of our body. Why it is called policeman? It restricts the infection to a particular space, particular place. Avoid so that generalized peritonitis doesn't develop. Who given this name? Rutherford Morrison was the person who given this name to greater omentum, the abdominal policeman. Greater omentum attempts often successfully to limit intraperitoneal infective. Just a minute. As in cases of acute appendicitis, omentum is the thing which usually limits the infection. Otherwise, it can develop generalized peritonitis. So it's a very important organ in our body. Even in some patients of hernia, if you are not interested in the class, you can go. Omentum plugs the neck of hernial sac, and it prevents the intestine to go into the hernial sac. It's a very important thing to avoid intestinal obstruction in cases of hernia. It can be a cause also likely due to obstruction, maybe due to the cause of obstruction acting as a large adhesion. The omentum is usually involved in tuberculous peritonitis and carcinomatosis of peritoneum. The common entity which involves omentum is torsion of omentum. Torsion of omentum is a very rare emergency, consequently is seldomly diagnosed correctly because it's a very common. It usually presents as a pain, abdomen guarding and rigidity, may be mistaken as appendicitis. It can be primary or secondary to adhesions of omentum to a old focus of infection or hernia. Patients are usually middle-aged man, obese man. Tender lump may be felt in the abdomen. Blood supply having been jeopardized. Twisted mass sometimes become gangrenous, in which bacterial peritonitis may follow. Treatment is surgical. Surgical removal of the omentum just above the ligature. Second topic is mesentery. The most common entity which you can find in mesentery, in disease mesentery, is mesenteric injury, usually due to the trauma. A wound of the mesentery can follow severe abdominal contusion, is a cause of hemoperitoneum because of mesenteric vessels bleeding. More commonly, it is injured by a torsional force, so-called seat belt syndrome. The possibility should be every case of trauma with shock, the possibility of mesenteric injury should be kept in mind. Other than the solid organ injuries, which are liver and spleen, it's very common. And the other thing is ischemia of the mesentery. Ischemia of mesentery, which may lead to the mesenteric injury if it is involving the mesenteric vessel, then it causes gangrene of the gut. In this condition, we have to remove this part of the gut which is gangrenous. So resection of gut should be required. Apart from mesentery, the other common condition in mesenteric lymphadenitis. Mesenteric lymphadenitis can be non-specific or the tubercular. Acute non-specific is idiopsychic lymphadenitis, difficult to distinguish from the tuberculous mesenteric lymphadenitis. It is now much more common than the tuberculous variety. The etiology often remains unknown, although some cases are associated with Yersinia infection of ileum. In other cases, an unidentified virus is also blamed. About 25% of cases, a respiratory infection precedes an attack of non-specific mesenteric lymphadenitis. It's a self-limiting disease, never fatal, but may be recurrent. Its significance mainly lies in its differential diagnosis with appendicitis, especially in children. The diagnosis of acute non-specific mesenteric lymphadenitis is present during childhood. Acute non-specific lymphadenitis is a common condition in childhood. Typical history is one of short attack of central abdominal pain lasting for 10 to 30 minutes, commonly associated with vomiting. In more than half of cases, the temperature is elevated. Abdominal tenderness is poorly localized, and when present, shifting tenderness is a valuable sign for differentiating the condition of appendicitis. As we all know, appendicitis patients having shifting tenderness usually starts around and just above the umbilicus and then shifted to right iliac fossa. In these cases of appendicitis, you will not see such kind of shifting. In some cases, neck, axilla, and groin should be palpated. In every case, it should be palpated for lymph node. You may find lymph node in neck, axilla, and groin. Leukocyte count you may be find increased up to 10 to 12,000. The treatment is mainly assurance, bed rest, and the simple analgesia. As we all know, it's not a common bacterial condition or common bacterial infection. It's a self-limiting disease. But painkiller should be given just symptoms of patient. In second exam, if at a second examination, if you ask later, acute appendicitis cannot be excluded. Safer to perform either appendectomy or diagnostic laparoscopy. As I have just told you, it's common differential diagnosis of lymphadenitis is appendicitis. It should be excluded properly. If we are not able to exclude appendicitis, or patient is having pain, still pain and tenderness, then go for appendectomy or diagnostic laparoscopy. If appendix is inflamed, then remove the appendix. In very acute cases, you may find red colored walnut size lymph node. The tuberculosis of mesenteric lymph node, the other entity of lymph node, mesenteric lymph node. Tuberculous mesenteric lymph node is considerably less common than acute non-specific. Tubercular bacilli usually, but not necessarily bovine. Usually it's a bovine, but not necessarily. Usually ingested and then entered via the Peyer's patch to the mesenteric lymph node. Sometimes only one lymph node is infected. Usually there are several. Occasionally maybe massive involvement will be there. The presentation may be with the abdominal pain, a rare differential diagnosis of appendicitis, or with the general constitutional symptoms of tuberculosis like fever, malaise, weight loss, loss of appetite. These may be the constitutional symptoms of tuberculosis. Calcified lymph node may be demonstrated on a plain radiograph. Very difficult to distinguish it from ureteric or renal stone. And the other entity is misty mesentery. Misty mesentery is a pathological increase in mesenteric fat, usually diagnosed with the multi-detector CT scan performed during daily clinical practice and may be identified incidentally. In patient with acute abdominal disease, misty mesentery may be considered as a feature of some underlying disease. Otherwise, it may represent an incidental finding on CT. Follow-up scan may be required to dictate whether further investigation is required or not. This is a picture showing mesenteric center में जो दिख रहा है आप लोगों को ना center में. The thing is that fibrous, inflamed, and concentrated at one place. Otherwise, mesentery is usually spreaded like this thing. The completely inflamed, fibrous, and one side located. The other entity of mesentery is mesenteric cyst. Mesenteric cyst occurs in the mesentery of, it may be occurs in a small or large intestine, but it's commonly seen in small intestine and less commonly in colon. It is mesenteric cysts are classified in 4 types: chyliolymphatic, enterogenous, urogenital remnant, and dermoid. The chyliolymphatic cyst. Although all mesenteric cysts are very rare, but the most common out of these are chyliolymphatic cysts, usually arising in congenitally misplaced lymphatic tissue that has no afferent communication with the lymphatic system, most frequently in the mesentery of ileum, usually seen in the mesentery of ileum. The thin wall cyst, which is composed of connective tissue lined by flat endothelium, is filled with clear lymph or less frequently with the chyle, varying in consistency from watered milk to cream. Occasionally the cyst attains such a great size. More often unilocular, sometimes multilocular. Unilocular, multilocular difference आता है आप लोगों को? Anyone knows what is unilocular, what is multilocular? Unilocular is single cavity. It's like a balloon filled with water. It's a unilocular. And the balloon के partitions कर दिए suppose करो आपने ना, अलग अलग portions के अंदर liquid भरा हुआ है, that is multilocular. In these cases, unilocular you can drain by a single incision. In multilocular, you have to either remove it completely or you have to enter into the cyst, then just remove all the loculi, then you will be able to completely clearance of that. Chyliolymphatic cyst is almost invariably solitary, although there is an extremely rare variety in which multiple cysts can be found in various parts of mesentery. Chyliolymphatic cyst has a blood supply that is independent part from the adjacent intestine. Thus, enucleation is possible. Very important for surgical part of view. Its blood supply is totally different. So, if we remove mesenteric cyst, there will not be any harm to gut supply. And the other type of cyst is enterogenous cyst. These are believed to be derived either from the diverticulum of the mesenteric border of intestine that has become sequestrated from the intestinal canal during embryonic life, or from a duplication of intestine. The enterogenous cyst has a thicker wall than the chylolymphatic cyst and is lined by mucous membrane, which is sometimes ciliated. The content is mucinous and either colorless or yellowish brown as a result of past hemorrhage. The muscle in the wall of is relatively boring, but you have some short notes on these topics. No? So you have to cover these topics. The muscles in the wall of enteric duplication cyst and the bowel which with which it is in contact have a common blood supply. Consequently, removal of cyst always entails resection of the portion of gut. Okay. Chylolymphatics may they have different blood supply. That is why gut is not needed to be resected. In enterogenous cyst, the same blood supply. That's why the portion of the gut should be removed. The urogenital remnant, a cyst developing in the retroperitoneal space often attains very large dimensions, has first to be distinguished from a large hydronephrosis. Even after the latter condition has been eliminated by scanning or urography, a retroperitoneal cyst can seldom be distinguished with certainty from a retroperitoneal tumor until displayed at operation. Maybe unilocular or multilocular. The common clinical features of mesenteric cyst. Mesenteric cyst usually occurs in adults with mean age of 45 years, twice as common in women as it compared to men. Approximately a third of cases occurs in children younger than 15 years of age. The mean age of children is 4.9 years. The most common presentation is a painless abdominal swelling with characteristic physical signs. It's a, as we all know, cysts are fluctuant swellings. So it's a fluctuant swelling near the umbilicus. Swelling moves freely in a plane at right angle to the attachment of mesentery. There is a zone of resonance around the cyst. Other presentations are with recurrent attacks of abdominal pain with or without vomiting, pain resulting from recurring temporary impaction of food bolus in a segment of bowel narrowed by the cyst, or possibly from the torsion of mesentery. Torsion of that portion of mesentery containing the cyst. These are the complications which may occur in cyst. Rupture of cyst often as a result of temporary trivial accident. Hemorrhage into the cyst and the infection. The investigations are ultrasonography and CT scan will demonstrate the lesion. There is no suitable medical treatment is available. The only treatment is surgical. The goal of surgical therapy is complete excision of the mass. Preferred treatment for the mesenteric cyst is enucleation, completely removal of the cyst with its complete wall. Although bowel resection is frequently required to ensure the remaining bowel is viable. If the blood supply of bowel is hampered, then it will become gangrenous later on. So we have to remove that portion of bowel also, and resection and osmosis is done. If enucleation or resection is not possible because of either the size of the cyst and its location, deep root, sometimes it's located deep in the root of mesentery. In these cases, partial excision or marsupialization can be done. Approximately 10% of patients require this type of treatment, the partial removal and the marsupialization. If the marsupialization is performed, the cyst lining should be sclerosed with 10% glucose solution, or the diathermy or tincture iodine. Recurrence rate in cases of cyst are 0 to 13%. The differential diagnosis of mesenteric cyst: peritoneal inclusion cyst, serosanguinous cyst, probably traumatic in origin, although history of an accident is seldomly obtained. Tuberculous abscess in the mesentery and the hydatid cyst of the. The other thing which we will discuss today is retroperitoneal space and its diseases. The retroperitoneal fibrosis is a thing which is rarely diagnosed in cases of retroperitoneal space diseases. It's characterized by the development of a flat gray-white plaques of tissue, which is found first in the low lumbar region but then spreads laterally and upward to encase the common iliac vessels, ureter or aorta. Histological appearance may vary from acute inflammation with a high cellular content interspersed with bundles of collagen through to one of acellularity to mature fibrosis or calcification. Etiology is in mostly cases it's idiopathic. In other patients can be known. The clinical presentation may be one of the ill-defined chronic backache or result of compromise or occurs as a result of compromise to involved structures. Lower limb or scrotal edema structures of venous occlusion. These are basically due to retroperitoneal structures got narrowed by the fibrosis of retroperitoneal fibrosis. In such cases, if the lower limb vessels are iliac vessels are compressed with the fibrosis, then you will find the edema in lower limb, scrotal edema due to venous occlusion or the chronic renal failure secondary to ureteric obstruction. Treatment will be directed to the cause. The cause should be removed. Fibrosis is there. The immunomodulation with steroid, tamoxifen, restoration of flow of affected structures, surgical removal can be done. And in cases of ureteric obstruction, ureteric stenting can be done. Retroperitoneal abscess. The retroperitoneal space can also be a site for abscess formation, which for practical purposes is almost synonymous with psoas abscess. Psoas abscess is relatively uncommon diagnosis. At a start of 20th century, psoas abscess was mainly caused by TB of the spine with sports disease. With the decline of Mycobacterium tuberculosis as a major pathogen in rich countries, psoas abscess was mostly found secondary to direct spread of infection from the inflamed or perforated digestive system or urinary system. In recent years, a primary psoas abscess due to hematogenous spread from an occult source is more common, especially in immunocompromised and older patients, as well as in association with IV drug misuse. Clinical presentation is with backache, lassitude, fever. A swelling may point to the groin as it tracks along the psoas abscess, iliopsoas muscle. Pain may be elicited by passive extension of lower limb. Thank you.